Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 315 of our pharmacotherapy series, which majors in hypertensive crisis. The first question reads, CXM, a 52-year-old Caucasian man, is admitted to the hospital with a 3-day history of increasing exertional substernal chest pain, without shortness of breath, diaphoresis, nausea, and vomiting. His history is significant for poorly controlled hypertension, glaucoma, and angina pectoris. Prior medications include dorzolamide ophthalmic drops, atenolol, hydrochlorothiazide, and oral nitrates. Physical examination reveals an anxious man who is alert and oriented. He has a BP of 210 systolic, 146 diastolic without orthostasis, and a regular pulse of 115 beats per minute. Bilateral hemorrhages and exudates are present on fundoscopic examination. The lungs are clear and the point of maximal impulse is displaced. There are no murmurs or gallops. Examination of the abdomen is unremarkable, and there is no peripheral edema. The neurologic examination is normal. Significant laboratory values include the following: blood urea nitrogen of 49 mg per deciliter. Serum creatinine of 2.8 mg per deciliter. Serum creatinine was previously noted to be 1.2 mg per deciliter. Urinalysis shows proteinuria and hematuria. The electrocardiogram demonstrates sinus tachycardia with left axis deviation, left ventricular hypertrophy, and nonspecific STT wave changes. The chest radiograph reveals mild cardiomegaly. CXM is given nitroglycerin sublingually and 1 inch of nitroglycerin ointment is applied topically. He is started on IV labetalol. Is this choice of treatment reasonable, considering CXM's angina and acute kidney injury? The presence of chest pain, retinopathy, and new-onset renal disease, as well as the magnitude of the BP elevation in CXM, classifies his presentation as a hypertensive emergency that warrants a prompt reduction in BP. Sublingual and topical nitroglycerin may help in acutely and temporarily lower his BP and relieve his chest pain while waiting for more definitive treatment to be implemented. IV labetalol has been used successfully in hypertensive emergencies. Labetalol blocks both beta and alpha adrenergic receptors and also may exert a direct vasodilator effect. The beta blockade is non-selective with beta to alpha potency of 3:1 for oral and 7:1 for IV. Labetalol is advantageous in CXM because the immediate onset of action will reduce peripheral vascular resistance without causing reflex tachycardia. Myocardial oxygen demand will be reduced and coronary hemodynamics will be improved, making this agent an excellent choice for patients such as CXM, with anginal symptoms or ME. In addition, IV labetalol does not significantly reduce cerebral blood flow, therefore, it may be useful in patients with cerebrovascular disease. Phenyldopam or nitroprusside could also be used to treat CXM. Phenyldopam could be considered, but CXM's history of glaucoma would preclude its use. Additionally, phenyldopam would not be preferred due to the potential for reflex tachycardia and risk of worsening ischemia. Treatment with nitroprusside would expose CXM to the potential risk of cyanide and thiocyanate toxicity with his new-onset acute kidney injury. In contrast, labetalol has been used successfully in patients with renal disease without deleterious side effects. Labetalol is eliminated by glucuronidation in the liver, with less than 5% of the dose being excreted unchanged in the urine. The next question reads, what cautions should be exercised when using labetalol in CXM? Labetalol's disadvantages are primarily related to its beta-blocking effects. Therefore, it should not be used in patients with asthma, heart block greater than first degree, or sinus bradycardia, and it should be used with caution in patients with decompensated heart failure. None of these are present in CXM. Like other beta blockers, labetalol should also be used with caution in patients with beta. Labetalol has been effective in the treatment of hypertension associated with pheochromocytoma and excess catecholamine states, as well as those with rebound hypertension from beta blocker withdrawal. However, because labetalol is primarily a beta blocker, paradoxic hypertension may occur in patients with pheochromocytoma. These individuals have adrenal tumors that excrete high amounts of norepinephrine, which results in relatively unopposed alpha receptor stimulation. More clinical experience is required before labetalol can be recommended in patients with pheochromocytoma. The next question reads, how should parenteral labetalol be given to CXM? IV labetalol can be given by pulse administration or continuous infusion. Bolus injections are administered, beginning with 20 mg given over 2 minutes, followed by 40 to 80 mg every 10 to 15 minutes until the desired response is achieved or a cumulative dose of 300 mg is reached. The desired response is usually achieved with a mean dose of 200 mg in 90% of patients. The maximal effect occurs within 10 minutes and the antihypertensive response may persist for more than 6 hours. Because the rate of BP reduction is accelerated with an increase in infusion rate, a controlled continuous infusion may provide a more gradual reduction in arterial pressure with less frequent adverse effects. The infusion can then be started at a rate of 2 mg per minute and titrated until a satisfactory response is achieved or until a cumulative dose of 300 mg is reached. The next question reads, CXM was treated with a labetalol infusion and required a cumulative dose of 180 mg to achieve a DBP of 100 mm of mercury. His anginal symptoms resolved almost immediately, but 3 hours after the infusion, CXM became faint and dizzy while ambulating. Should oral labetalol be withheld in CXM? Postural hypotension and dizziness are dose-related and more commonly associated with the IV route of administration. CXM should remain in a supine position after the IV administration of labetalol, and his ability to tolerate an upright position should be established before permitting ambulation. Oral labetalol can be given to CXM when his symptoms resolve. There is no correlation between the oral maintenance dose and the total initial IV dose. CXM should be started on an empiric dose of 100 to 200 mg of oral labetalol 2 to 3 times per daily, and this should be titrated as necessary. The next question reads, what other side effects can occur with labetalol therapy? Other side effects commonly associated with labetalol include nausea, vomiting, abdominal pain, and diarrhea in up to 15% of the patients. Scalp tingling is an unusual side effect that has been reported in a few patients after IV administration. It tends to disappear with continued treatment. Other side effects include tiredness, weakness, muscle cramps, headache, and skin rashes. The next question reads, would parenteral nitroglycerin be an acceptable alternative to labetalol for CXM? Hypertensive emergencies in the setting of unstable angina or myocardial infarction requires an immediate reduction in BP. Nitroprusside has been used successfully, but IV nitroglycerin can have more favorable effects on collateral coronary flow in patients with ischemic heart disease. By diminishing preload, nitroglycerin decreases left ventricular diastolic volume, diastolic pressure, and myocardial wall tension, thus reducing myocardial oxygen consumption. These changes favor redistribution of coronary blood flow to the subendocardium, which is more vulnerable to ischemia. At high dosages, nitroglycerin dilates arteriolar smooth muscles, and this reduction in afterload also decreases myocardial wall tension and oxygen consumption. IV nitroglycerin has a rapid onset of action and a short duration, and is easily titratable. It is generally appropriate to begin IV nitroglycerin in the dose range of 5 to 10 micrograms per minute, increased as needed to control pressure and symptoms. The usual dose is in the range of 40 to 100 micrograms per minute. The major limiting side effects are headache and the development of tolerance. In general, IV nitroglycerin is well suited for use in patients such as CXM who have angina or in patients who have hypertensive emergency associated with myocardial infarction or coronary artery bypass surgery. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 316.